Thank you. So thank you for having me. It is really a pleasure. I think I may enjoy the talk more than how you guys receive it, but it's been great in the past, and I have no doubt it'll be the same today. So we may have worked indirectly or directly with one another, and if we have not, I have no doubt that you will come across some of the patients or ideas that are expressed in this lecture, which is the approach to the patient with new seizures. So we're going to go over some definitions, some history taking and physical that are unique, not just to a neuro exam, but to someone as a seizure specialist, some diagnostic tests, neuroimaging, EEG, and treatment. So first, just to define, seizure comes from the Greek word to take hold. It is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. It can affect, depending upon where it comes from, sensory if it's parietal, motor systems if it's frontal, autonomic function, consciousness, emotional state, memory, cognition, or behavior, most of the latter of which belong to the limbic system or temporal lobe. And the difference between having a seizure and having epilepsy used to be defined by the first point here, which was that you had to have at least two unprovoked, we'll get into what reflex means, but two unprovoked seizures greater than 24 hours apart. So when I started as a neurology first year at Sinai, many years ago, I remember one of the ER docs asked me, after they have the seizure, I just send them out and tell them to come back after they have the second one to start medications. And that really used to be the guideline, even though it felt kind of crummy. But then in 2017, the International League Against Epilepsy redefined what it meant to have epilepsy, which is having one unprovoked seizure and the probability of a second one that's greater than 60%. We'll see an example of this. But what this means is that if someone comes in with a first-time seizure and you see that they've had a stroke in the past, or they have a big meningioma, or they have something in their brain, then you're going to say, wait a minute, your probability of having a second seizure is greater than 60%. And that number is based on the meningioma literature, which says if you have something in there that is pushing on your cortex, as meningiomas often do, which is where we think seizures come from, the outer layer of the brain, then you should be put on medicines after a first-time seizure. Now, the first patient I saw today came to me with a history of having 4 seizures. I took a full history. I did a physical. His wife gave me eyewitness information. He gets a feeling, he sits down, then he has a convulsion. And then at the end of the hour visit, he's like, does it matter that all of these occurred in the setting of me stopping drinking excessive amounts of alcohol? And I was like, yeah, that matters. So this is where the word unprovoked come from. So all of his seizures were provoked. He had them all in the setting of abruptly stopping excessive amounts of alcohol. So if that's the case, and over the past 2 years, he has not had excessive amounts of alcohol, and he's not had what is clearly a seizure. So if you can take away or reverse what's causing a seizure, then you do not get diagnosed with epilepsy. And the third way to get to a diagnosis of epilepsy is if you have a single seizure and you fall into a particular age group, which can bring you into what are these known as epilepsy syndromes. The best known is absence seizures. So if you see someone who has a spacing out episode and an EEG that shows these generalized 3 Hertz spike and wave, even after one space out, and they're young and they have this EEG, they get a diagnosis of epilepsy as well. Okay, so statistically speaking, 1 in 10 people have a seizure over the course of their lifetime, which is huge. I'm sure that some of the people in this lecture today have, even just like between family and friends, have had someone that's had a seizure. About 1 in 26 go on to develop epilepsy, which is only, I usually say, about 3%. So after someone comes in with a first-time seizure, and let's say they don't have anything on their MRI, their chances of developing a second seizure are still pretty low. About 3.4 million people in the US and 64 million in the world have epilepsy. 3 million are adults and 1 million are aged 55 and older. So how do we classify seizures? We no longer say grand mal. We no longer say petite mal. We no longer say simple partial or complex partial. So all those terms are out. And the new way of defining seizures is by saying they're either focal, generalized, or unknown. The only older phrase that kind of got to stick was absence. So that is a generalized seizure. They're usually in kids who are just spaced out for a couple seconds. But most of the seizures that you will see over the course of your career are focal onset, because in adulthood, the piece of the pie is mainly focal. A small percentage are, young people that go on to develop that have generalized epilepsy as kids, that have generalized epilepsy as adults. Very rarely we'll see an adult present with generalized onset. But the reason why people have focal onset is because of traumatic brain injury and tumors and stroke, and these are all risk factors for seizures. And if one were to have a seizure and be completely conscious the whole time, we call that a focal aware seizure, or FAS. And if they have impairment in their level of awareness, we call it a focal impaired aware seizure. Both focal aware and focal impaired aware can become focal to bilateral tonic-clonic. And that's why we always ask on exam, was there an eye deviation or a head deviation? Because that usually tells you the contralateral hemisphere is responsible for the seizure onset. And we also ask if there's an aura, because an aura, by definition, is a focal aware seizure. Generalized onset means both sides fire at the same time. And unknown is if you don't have eyewitness information, you just don't have enough information to make that call. So you can say, seizure, unknown onset. Okay, so again, focal seizures originate within networks limited to one hemisphere, sometimes even one lobe. And generalized seizures really rapidly engage bilaterally. Okay, so what are you trying to do with the new onset seizures? You're trying to figure out, is it an acute symptomatic seizure, which means that it happened in close temporal association with a transient central nervous system or systemic insult. So good examples would be a diabetic who gives themselves too much insulin. That would be a provoked seizure. Acute symptomatic seizures are seizures that happen within 7 days of traumatic brain injury or a stroke. And these are, the seizure itself in an acute symptomatic seizure is presumed to be an acute manifestation of the insult. And single unprovoked seizures occur in the absence of precipitating factors and may be caused by a static or progressive injury. So if you are years out from your stroke, that is considered unprovoked at that point. If you have a stroke and within a week have a seizure, you might put someone on medication just for 7 days, but then stop it. But if they have a seizure or their first seizure 2 years out from their stroke, you're going to put them on medication because then it's unprovoked at that point. The process of epileptogenesis, or the formation of the underlying predisposition to seizures, is there. It's not going away or getting better at that point. And then, of course, non-epileptic events, which we'll touch upon in a minute. So here again, seizure-like spell, you see it, you want to know if it's epileptic or non-epileptic. Very often the term non-epileptic is used to refer to psychogenic or non-epileptic seizures. I despise the term psychogenic non-epileptic seizures because all I hear is psycho when you tell someone they have something like that. But we see it a lot and it's still in the nomenclature. But if you read any of my notes, I just call it a non-epileptic seizure, going against the grain. But other things that are considered non-epileptic are syncope, which is the most common first time visit I see in my office. Is it syncope or seizure? Migraine can look like a seizure, toxic metabolic states can look like seizure, like altered mental status, cerebrovascular, parasomnias. I get a lot of referrals from Andrew Varga for some sorts of things that happen at night that could be a seizure or could be a parasomnia, tremors, and movement disorders. So not everything that shakes is a seizure. And again, we sort of went through the other side of this diagram. So the most important thing, I think, in making the diagnosis, so unlike a lot of the things that you all do, we can't directly visualize the electricity of the brain. So even cardiology can get closer to the heart than we can to the brain. GI is awesome. You get a colonoscopy, like your tools are great in medicine. And in neurology, we have an EEG, which was invented by a crazy, crazy man in the 1940s, but it's the same device that we use today. So we have to go mainly, the diagnosis is a clinical one. And so the best thing we could have is witness testimony. And the last thing after you do, and like taking a history and you have like 10 other consults to see, is like call a friend or family member or witness on the phone to actually see what they saw, to get the history of what they saw. But that usually will give you the diagnosis. So, and I always say this, so people experience seizures very differently, they themselves, from the witnesses. So that is the most important thing. But when we talk to someone, we want to get, if we're going to go into the nitty gritty, we want to get a birth history. So being premature does predispose you to seizures later in life. We want to assess developmental milestones. So did you walk on time, talk on time? We know that things like autism predispose people to having seizures. So that's a biggie. Febrile seizures, so seizures with a high fever as a baby, also predisposes you to seizures as an adult, a very small percentage. We ask about meningitis, encephalitis, and a family history. And things, of course, in the history that would predispose to seizures, many of which we mentioned before: stroke, traumatic brain injury, having a history of a neurodegenerative disorder like Alzheimer's. Alcoholism, so this gentleman that I saw earlier, he has dizzy spells and AFib. And so just being an alcoholic predisposes him to having seizures. So his dizzy spells may be seizures, even though he's not having his convulsions, and brain tumors. So we ask also about being a spacey kid, whether or not they've had early morning jerks. So a spacey kid would be someone with absence seizures. Early morning jerks is juvenile myoclonic epilepsy usually, but these present later in adulthood. Teenager usually, juvenile myoclonic epilepsy, excessive daytime sleepiness, waking up with muscle sore, tongue having been bitten, or with urinary incontinence, funny smells or tastes, deja vu, which we've all experienced. So you're going to go through this review of systems and everyone's going to be like, oh my goodness, I'm having seizures. It's just not true. So deja vu is totally normal. Your hippocampus is doing something very funny, but having deja vu every day is not normal. Jamais vu is where you go someplace familiar and it feels foreign. Warm rising epigastric sensations, a dissociated feeling, which is normal when you're driving, but not every other moment of your life, and lost time. So if you start out in one place and you get to someplace else and you have no idea how you got there. So all things that could be seizures. So again, an aura is a small seizure and often indicative of focal epilepsy. We want to know about surgical history. So having had any kind of neurosurgery, even if it wasn't for epilepsy, predisposes the patient to having seizures. Medications that reduce the threshold. So this is where it might be good to come in. So, and have a good sense of what can. So bupropion or Wellbutrin is the biggest offender. So anytime anyone comes in, even after a first time seizure, and we think it might be provoked in some way, if they're on bupropion or Wellbutrin, we're not sure it's related, it's one cause among many, I just take them off. It is not worth having even had one seizure and being on bupropion. Other things that can lower the seizure threshold, and in some cases trigger seizures, so tramadol, fluoroquinolone, cephalosporins, clozapine. So whenever you call a neuroconsult for one of your really sick patients and they're on all these medicines and they say, take them off these medicines. And you're like, why? But it's because it may lower the seizure threshold. So the diagnosis of seizures or epilepsy, again, is a clinical one based on history and physical exam. So you don't need to have any of these other tests show any abnormalities. If your clinical suspicion is high, we make the diagnosis and we treat. So physical exam. So lateral tongue bites are seen in about 22% of patients with all types of epileptic seizures. Most of you have probably heard of a Todd's paralysis. It can look like a stroke, where one side of your body is temporarily weak. Usually, again, the contralateral brain is the one where the seizure focus started from. And that can be seen after a seizure. We say, did you have weakness on one side versus the other? Any kind of nuchal rigidity on physical exam would alert you to meningitis or encephalitis. And especially in the setting of fever, you would do a spinal tap. And then asterixis for toxic or metabolic causes. So the tools that we have. So usually in the emergency room, most of this stuff is done. So blood work like CBC, BMP, looking for hypo or hypernatremia, hypo or hyperglycemia. Those are the biggest offenders. Liver function tests, FOS-MAG, thyroid, we do a UTOX, obviously drugs. Look for infection, UA, chest x-ray, only do an LP if we suspect meningitis, encephalitis, or a subarachnoid. And then paraneoplastic limbic encephalitis. Do I have any takers on having heard of this entity before? Has anyone heard of Brain on Fire? Seen the movie, read the book? I can see a couple nods. I can't like zoom through fast enough, but those are causes of seizures. Unusual, but very interesting and can be refractory. Prolactin, we don't check it. And if I bring it up in a conference on the neurology side, they all tell me to shut up. So we don't check prolactin. But people ask about it. But you have to have a baseline prolactin in order for a prolactin level post-seizure to be relevant. And you have to draw a prolactin level within like 20 minutes of a seizure for it to be accurate. Okay, neuroimaging, CT head and MRI. So if someone has a history of epilepsy and they have a seizure, we don't get a CT head or MRI after each seizure unless they've hit their head. But obviously someone with a first-time seizure gets a CT head and then should get an MRI as an outpatient or inpatient, depending, and EEG. Okay, so again, the reason we don't use prolactin, but why it's interesting is that it can differentiate generalized or focal seizures with impaired consciousness from what other people call psychogenic non-epileptic events. So it's good for that. It must be measured 10 to 20 minutes after an event, and it must be compared to a baseline that has to be at least 6 hours prior to the suspected event or taken at some other time point. And what I think is interesting and what makes it even less useful is that prolactin elevations can be seen with syncope and cannot differentiate between an epileptic seizure and syncope. And one of the things we see with syncope is something called convulsive syncope, which is people will have a fainting spell and they will not get completely flat. And the body has a built-in mechanism to shake you down because it needs oxygen to eliminate gravity. So people who have a fainting spell and wind up like propped up oftentimes will convulse, but it's not a seizure. It's just a convulsive syncope. Okay, imaging. So emergent neuroimaging is for structural brain lesions if they're suspected, new neurological deficits, persistent altered mental status, recent trauma, and prolonged headache. So this is an example of a woman with a first-time seizure. She was 58, left-handed. She's a musician. She's a violinist. She had right leg spasms while she was sitting on the couch with her family. She screamed, lost awareness, and had full body convulsions with foaming at the mouth. And so unlike what we did in the past, which was, you know, come back after you have your second event, she had a CAT scan that looked like this. This is a meningioma, a left parafalcine meningioma, and you can see tons of vasogenic edema. And so she was put on medications immediately, obviously had the meningioma resected and hasn't had a seizure since. Okay. So what a CAT scan can miss is low-grade gliomas, hippocampal sclerosis, which is scarring of your hippocampus, which is your memory center, cavernous malformations, and malformations of cortical development. So cortical dysplasias, what are known as periventricular heterotopias. So when we're in utero, the gray matter actually sits around the ventricles, and then all these hormones get released, and the gray matter is told to go to the cortex. But sometimes there's a piece of gray matter that doesn't get the memo and sits within the white matter. And then as an adult, people present with seizures, which is bizarre, but true. Okay, this is an example of that. So here's an MRI. This is a person who had a completely normal CAT scan. And then looking at these all day, I might have missed this one also, but you can see, so gray matter here looks gray and white matter looks black. Fluid is white, and right around the ventricle, where you should only have white matter, there is this like little gray fuzzy roundish thing, which is a gray matter heterotopia, and this was the cause of this person's seizures. What we do at Sinai is we actually have a super awesome magnet, which is a 7 Tesla MRI. It's a research MRI. But what we found is when we took a bunch of epilepsy patients who had normal 3 Tesla MRIs and put them in a 7 Tesla, about 20% of them had abnormalities that you couldn't see on a 3 Tesla. So as our imaging gets stronger and better, I think we will be able to visualize lesions that we couldn't see previously. So our other tool is EEG. So you're going to have to believe me, but where my cursor is normal brain wave, just sort of these little sinusoidal waves. And I think you'd agree that this stuff where it's just very high amplitude and rhythmic is seizure wave. These are spikes and polyspikes in some way. They cross the baseline multiple times, spike and wave. This would be an absence seizure as it's generalized. It takes up the whole page. And then the EEG goes back to being completely normal. So we have 3 EEGs, routine, ambulatory, and video. So a routine EEG, typically we do in the setting where there's no emergency.
The only thing that's not clear, did he get the transvenous pacing placed or it was removed?
So it's actually one of my questions. From what I saw, it looks like it's been removed.
Sorry, that had to do with me. It's okay. No. So an EEG can differentiate between a generalized seizure and a focal seizure. In patients with new onset seizures, 29% will have a seizure wave on their first EEG, which is a super low percentage. There's a slightly higher yield if you do the EEG within 24 to 48 hours. So there is some kind of urgency with getting it done timely, but you can't do an EEG in the ER. It's just geographically impossible in most cases. But when does someone get admitted and when do you order a continuous EEG? So in someone with new onset seizures who does not return to their baseline neurologically within 30 to 60 minutes after the end of a seizure. So the reason for that is there's a high suspicion for non-convulsive seizures or non-convulsive status. So it's where the EEG is going crazy, but you don't see anything clinically. If you see someone waxing and waning in their level of consciousness for the same reason, and if there's focal dysfunction unexplained by a structural lesion, so someone has a weakness on one side and you get a CAT scan or an MRI and you don't see a stroke, you get obviously an EEG, a long EEG. So this is an example of someone who was admitted to medicine. So it's a 50-year-old man with diabetes. This is case is about a year and a half old. 50 years old, history of diabetes with he came to the ER after 2 convulsive seizures in the setting of hyperglycemia, the 400s. On exam, he was inattentive and pervasive. He had episodes of speech arrest with chewing mouth movements, so oral automatisms, and horizontal nystagmus. in between these episodes, he was able to answer questions, and this is taken from one of the consults. It was albeit in odd ways. For example, when he was asked how old you are, he would respond in Earth years. This was his CAT scan, which didn't show much of anything. And this is his episode. So he's laying in bed. He's not going to be really doing anything quite exciting. I'm going to give you some little EEG tutorial. So the top 4 lines are looking at the left temporal lobe, and the next 4 lines are the right temporal lobe, just homologous brain regions. So these 4 and these 4 should be totally symmetric. Then the next 4 here are the left side over the parasagittal region, and these are the right side over the parasagittal region. So if you pay attention to the right-sided electrodes, you could see that they kind of like built up in frequency and amplitude. They kind of, the lines got darker and bigger. And that's pretty much his seizure. But he's altered. He can sometimes answer questions. So this is his right brain. He's a right-handed guy. So that means language lives on the left side. So he was able to answer questions through a number of these seizures when he was tested. But you can see the waves went from being kind of faster and more of them to being slower and wavier. Now both sides are kind of slow, but you can see kind of almost qualitatively that the waves changed and now they're kind of going back to normal. So that was it, not much. He has a little bit of an arousal here. And I think the reason I put this one in is because I think within a week we had 2 patients with uncontrolled diabetes on medicine who were in focal status. So as much as we'd like to attribute this to his uncontrolled sugars, this definitely played a role. So we got an MRI, and very often in people who are in status, you can see cortical hyperintensity. So here is his right sort of parietal region. And you can see it's really bright here on the right side, which is where the status was coming from. So in patients with subclinical seizures, less than 50% are detected by routine 30-minute EEG, but the yield increases to greater than 90% within 24 to 36 hours of continuous EEG monitoring in patients with an acute brain injury and mental status change. There is approximately 35% chance of a seizure recurrence within 5 years following a new onset seizure in adults. And in persons who've had a second seizure, the risk of recurrence is 75, and that's why we treat after the second seizure for sure. So this is the Green Journal. It's like I mean, it's probably not as good as the New England Journal of Medicine. Definitely has a lower impact factor, but this is where we get most of our guidelines. But what tells us also to kind of treat after the first seizure is if a lot of this we've talked about, if they've had a prior brain insult, even a history of traumatic brain injury, you don't have to see that big meningioma, we would treat it. If you see an EEG with spikes on it, we're going to treat it. Again, if there's a significant brain imaging abnormality, so you can have a brain injury without even seeing something, but if you have a brain imaging abnormality, gonna treat it. And also if someone has had a nocturnal seizure, so a seizure out of sleep, we will often treat after the first seizure. So this is a guideline, I want to say from JAMA. I thought it was kind of useful because it was like a medicine algorithm. And I think it's nice just to kind of organize, but it basically, if you have an individual with a possible new onset seizure, we get, is the event description and witness report suggestive of a seizure? No. So then you look for something else. If it is, you move forward for a history and a physical exam with a seizure focus. Hopefully, if there's evidence of fever, focal deficit, or mental status change, then you're going to go for an acute symptomatic seizure workup. lab testing, CT, MRI, urgent EEG, and an inpatient admission. But if not, look for evidence of provoking factors, sleep deprivation, alcohol use, medications, or drugs, all of which, or I should say some of which we've all probably experienced, but haven't had seizures. And if there is, for the person that comes with seizure, you are going to you'll do an evaluation, but it'll be non-urgent. So as an outpatient, you can do a brain CT, an outpatient EEG, discuss lifestyle modifications, and no anti-seizure medicines if we think that there's a provocation. If there's an unprovoked seizure, you're going to do an EEG and an epilepsy protocol MRI, which just usually means thin cuts through the temporal lobe. And if the results are abnormal and consistent with an etiology of epilepsy, then we're going to choose a medication. If not, then we're going to say it's a first unprovoked seizure and defer medicine and say come back after the second. So this is Brain on Fire. It's a really short book. It's a very good read. They did make a movie, but this was a woman who was a journalist, and she presented with psychosis and seizures, and had what is now well known in my community as NMDA limbic encephalitis, where basically we don't know why, but the body makes antibodies to receptors in the brain and causes you to be psychotic and have seizures. And the other part of that triad is autonomic instability. I admitted someone very recently who, he's in the hospital now, he was presenting with jerk movements. He saw his internist referred him to a general neurologist. The general neurologist said it was anxiety and put him on Valium. It didn't help anything. And then he got COVID and went into the hospital, got steroids. And his daughter, who was a physical therapist, was like, COVID cured his jerks, because he stopped having the jerks after he came out of the hospital from COVID. And then about a month later, the jerks came back. And he has what's very classic as these fatiobrachial dystonic seizures, where his arm will jerk up and his face will pull. And he has another kind of limbic encephalitis, which is LGI1 limbic encephalitis. And these encephalitides do not respond to anti-seizure medicines. They only respond to immune therapies. So I thought this was interesting. This was an article that came out 2 years ago. And it said in people who present with new onset focal seizures, when they did autoantibody evaluations in 219 patients, and about 10% of them had autoantibodies, which is a huge amount. And the risk factor is being, I'm going to say a middle-aged person, so greater than 54, having goosebumps with a seizure, having some mood changes and reduced attention, an MRI that shows maybe a signal change in the limbic structure, so like the hippocampus and amygdala, and the absence of any risk factors. So you ran through your whole risk factor list. So about 10% of new onset seizures are due to these autoantibodies, which is super interesting. So treatment. So there's 3 ways I like to think about treatment. One is, are the medicines broad spectrum or narrow spectrum? All that means is, do they treat generalized seizures or focal seizures? You can think of them in terms of a timeline, when they were kind of invented, and you can divide them up by the channel that they kind of target. But broad spectrum means you don't know what kind of seizure someone has, so you give them a medication that covers everything. So Keppra or levetiracetam is probably, or it is statistically the most commonly prescribed anti-seizure medicine for seizures, and it's appropriately chosen, because if you don't really know, or you don't have the time to figure out what type of seizure someone has, you just give them Keppra and you're playing it safe. Because some of these narrow spectrum or focal medicines can exacerbate or make worse generalized seizures. Okay, so what do we take into consideration, and what do you think about maybe when you have a patient that comes to see with you who has epilepsy on top of 50 other medical problems? So you think about their age, because certainly some medications, as we'll see shortly in the slide, can interfere with some of the other medications you're giving them. And we also know that some medications cause problems in people over the age of 65 that they don't in people younger than 65. An example would be oxcarbazepine and carbamazepine can cause, so Tegretol and Trileptal can cause hyponatremia. And so we take age into consideration, and much more often in people greater than 65 years of age. We want to know the seizure type, so we know if we should do broad spectrum or narrow spectrum. Whether someone is childbearing, you would never give a woman of childbearing age Depakote. Newly diagnosed versus refractory disease. So how many medications have they tried before? If they have a history of seizures, meaning they are refractory. So current or previous anti-seizure medicines, so what they've tried and failed. Other medications, so if someone is on a statin or is on any kind of immunotherapy, the older medicines like phenytoin, which is Dilantin, carbamazepine, phenobarbital can interact with the metabolism. Also, women who are on oral contraceptive pills, a number of our medications decrease the efficacy of the oral contraceptive pill, so they should be warned that they should be using 2 forms of protection. Comorbidities, so sometimes we try to do 2 things at once. So if someone has a history of migraine, or let's just say another example, peripheral neuropathy and epilepsy, we might do gabapentin. For migraine, you might do something like zonisamide or Topamax. So depending upon their comorbidities, you might try to get at 2 of their problems with 1 of the medications. Long-term side effects, so the older medicines cause bone loss. So we worry about osteopenia and osteoporosis. Genetics, we're not even close to being there yet. And these are my references. Any questions?
Thank you so much, Dr. Fields. I think we have a question in the chat. Joe was asking, how long after the meningioma resection can we discontinue the AED, or should they remain on them forever since neurosymptoms is a risk factor itself?
It's a great question. So usually there's no hard fast rule. If someone has the meningeal resection, so presumably the cause of their epilepsy is now gone, I usually wait 6 months to 1 year before tapering off medications. And what I will do is I will get an EEG beforehand. So they've had their meningioma resection, let's say for argument's sake at 6 months, I'll do a routine EEG. If that doesn't show me anything, I might get an overnight EEG. And if I see seizure waves on that, I will not take their medicine away. I'll be like, your brain's still healing. Let's wait another 6 months. But if their overnight EEG doesn't show seizure waves, then I'm willing to try to come down. And then the next one, in what scenarios are patients with alcohol withdrawal on anti-seizure medicine? So many, right? I think my experience has been that more people with alcohol withdrawal seizures are on anti-seizure medicine than not on anti-seizure medicine, even though that obviously might not be the right thing to do. But then the answer is don't stop drinking, but which is the answer, or go to detox and appropriately come off your medicines, but come off your alcohol or come off alcohol. But I think what we find is sometimes in the emergency room, it's hard to suss out whether or not is someone's having an alcohol withdrawal seizure or they've actually developed epilepsy. So I think sometimes they just get started on medicines. I've had a couple patients over the years that clearly their seizures were provoked for sure. And if they were started on medicines, I will taper them off medicines. So I saw a ton sort of during the pandemic as like things were starting to open up again. So people have been drinking heavily when they were at home all the time. And then when they went back to work, I had about like 4 patients who started to have seizures out of the blue. And it was because they stopped drinking during the day. So even if, I think 1 or 2 of them had been started on anti-seizure medicine. So I took them off of it. But you can develop but alcohol is excitotoxic to the brain. And so sometimes we see people who are alcoholics have alcohol withdrawal seizures and also have non-alcohol withdrawal seizures. And in that case, if you can tease that out, then they should be on anti-seizure medicine. But often what happens is compliance becomes a real issue. And starting and stopping these medicines abruptly is not great. So it's hard. And then what are the post-ictal findings on MRI? So if someone is in status, usually we'll see stuff like this, where you see the cortical hyperintensity. You see it best actually on the diffusion weighted images. So the flare and all the other images will look okay. And then when you look for like the stroke related images, you'll see stuff like this, which is not a stroke, obviously. It's not in any kind of distribution, but sometimes you can actually see it even after a single seizure, but most people after a single seizure don't get imaged right away, but in status for sure. What else? ICU stuff, post-anoxic stuff. You probably come across a lot of seizure stuff. Post-anoxic myoclonus. It's a bad prognostic sign. I guess that's the take home for that one.
Guys, you're never so shy.
What's that?
I said they're never so shy.
They're not real.
I think there was a question earlier, Eric, I don't know if you had answer to this question, but he was asking, can general recurrence risk be more than 60% for someone without meningioma or any brain lesions?
Can the recurrence risk be, can general recurrence risk be greater than 60% for someone without meningioma or any brain lesion? Yeah, so if they have, so if they've had one seizure, right? But if it was out of sleep and their MRI is normal, we treat it because it's most likely to recur. If someone has a history, so I just saw a guy who was riding his bike drunk and was in a car versus bike accident, but this was like a year ago. And he has normal imaging. He broke his face, he broke like a couple of bones in his body. He has totally normal imaging. But he had a nocturnal seizure and a history of traumatic brain injury, even though his imaging looks normal. I put him on medicine because I thought he has two things against him. So definitely we see, I think it's, if you see it out of sleep, if their MRI is normal, but their EEG is abnormal, I put them on medicine after one. Yeah, brain lesion is easy because then you're like, I got you, like you're going on medicine. But if their MRI is normal, but they have, again, a history of traumatic brain injury, but you don't see anything, or a nocturnal seizure or an abnormal EEG, I would do it after, I would risk stratify them to greater than 60%. And then, do I come to Mount Sinai, MW?
I think
that west?
you mean Morningside or West, both of them.
So I live at West. I mean, I don't know. But, yeah, so I live at West. Really, like there's a couch to I live here. And I go to Morningside one Monday a month. We just started doing just like increase the routine EEG lab to be open 5 days a week at Morningside. And we also do ambulatory EEGs there. I don't do consults per se. Dr. Pyburns, do you know Dr. Pyburns? Yes, he's awesome. So there is like a general neuro consult service, but if it is a specifically epilepsy related question, you should call us. But I think in general, Dr. Pi, but he's like, he knows he's like what he, you know, he's a little older than me, and these older guys, they can do anything. So he knows everything, but he's great. But he would call if he's, you know, if there's an issue. And then what is the reason to treat nocturnal seizures? So for some reason, they tend to recur. It's why? More than any other seizure type. I'm going to also guess that there's a concern for SUDEP, so sudden unexpected death in epilepsy patients, which nobody likes to talk about, including myself. So it's unexpected because we don't really expect our patients to die out of the clear blue, but you have a much higher chance of asphyxiating yourself when you have a seizure out of sleep. So if you're face down and convulsing, so I think that's also embedded in the treat a nocturnal seizure. I do think they are more likely to recur, but I also think they hold a higher risk of SUDEP.
Thank you, Dr. Fields. I also had one more question. Sorry, that I think
No,
is
go
too
ahead,
long
go
to
ahead.
type out. What if a patient is having seizures like once in, say, 3 to 5 years, which is sort of what I mean is longer than the duration that you would give someone a trial of anti-epileptics to see if they were having another seizure? Then, like, how long would you treat them? Because their baseline frequency is so low to begin with.
So I would still treat, even though it's like you have to take a medication every day, there may be side effects to the medication. I would just, if you have someone for every, so there's some data for 2 years, there is also a chunk of data to wait 5 years. But in that case, I think it's a real conversation. Like you're really outside the typical window for when we, you know, would consider taking off, and what's the risk benefit. I would ask them like what they're doing. If they're, you know, are you driving? Are you, what kind of activities you're participating in? And the risk benefit might just be to like, okay, we're going to stay on for, you know, 10 years before potentially taking off. What I usually find myself in the situation where as I put someone on, they can't drive for a year even after one seizure, right? That's the driving restriction. New York State is 1 year, California 1 year, New Jersey, Pennsylvania 6 months. Each state has their own driving restriction. But if you tell someone they can't drive, and then when you say, oh, we might take you off your medicine, you do run the risk of having another seizure, they're like, whoa, 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 just let me stay on it. You know, it's not worth it. But it does happen where you have these people so far out from each of their seizures. And at that point, I would just say, okay, we're going to have to set a different timeline for you.
Since you brought up SUDEP, can you comment at all on ketogenic diets and prevention of SUDEP?
So ketogenic diet, has anyone tried it?
No.
Nobody's tried it. Your brain works much better on keto. You should try. It's really hard, but if you look at the website charliefoundation.org, it's really, it's quite good. So it's recommended for people with epilepsy. It's recommended for people with neurodegenerative diseases because it actually helps with cognition. Nobody knows how it works. There is some connection between the brain and the gut. They have done bacterial samples and stools and stool transplants because there is some like overgrowth of particular bacteria when it works for people. But we're not going to be doing stool transplant. That's not like, we're not there. But I just gave a lecture to the PhD students, and one of the PhD students had a sister who had absence seizures, which are usually very easy to treat, but she did not respond to medicines and then was a super responder to the ketogenic diet. So it really kind of an amazing thing. It works just as well as an anti-seizure medicine. So about 50% of patients will have a reduction in their seizures. There's about 10% of the ketogenic diet, people on ketogenic diet who are super responders and just need the ketogenic diet to have their seizures controlled. How that specifically, I'm not familiar with any literature that says like ketogenic diet is more preventative against SUDEP versus, I mean, the risk for SUDEP usually is you have people who are refractory to epilepsy, they have generalized seizures, and they're on multiple medications that like puts you into a much higher risk. And usually what we do is there's like three, so I say there's three buckets. You have medicine. Once you fail 2 medicines at adequate doses, then we try alternative therapies, which are ketogenic diet and Epidiolex, which is the FDA approved CBD oil, marijuana. And then the third bucket is surgery. So once you've sort of made your way through. But there are some people who don't mind making that lifestyle change. It's very hard if you have a sweet tooth and don't like artificial sweeteners. But
And what was that foundation again you mentioned?
so it's charliefoundation.org.
Okay.
So it's Charlie was a kid who was refractory to all medicines, had brain surgery, did much worse. Eric, you know what I'm talking about.
Yeah, they made a podcast about that.
They made a movie about it.
Oh, so
Also-
I first heard about it on the podcast. It was really good. I forgot the name of the podcast, but it was about that.
Yeah, so he so I think Meryl Streep is in the movie. I've never seen it, but I think it's called First Do No Harm. And he only responded to the ketogenic diet. He came off all his meds. So after stinking brain surgery, still seizing like nobody's business, they put him on the ketogenic diet. Eric, correct me if I'm wrong, because I didn't watch the movie. He gets put on a ketogenic diet, seizure free for decades, off of medicines. And I think now he's even off the ketogenic diet.
Yeah. So his symptoms stopped completely at 100% on ketogenic diet.
Wow. I love it when I learn something, so thank you. That's fantastic. I learned a lot more about seizures too. That's not the only thing I learned. I'm not a seizure expert, so. But I like your patients will ask you about all this kind of alternative stuff. So it's really helpful to you to be a little bit aware of it because, you know, they read it in the Times, they see a movie, they listen to a podcast, and they're going to ask you. So it's just good to be a little bit aware.
So it's really an interesting diet. It's kind of fun to try. If you, not that I'm recommending any of this, but off the books, if you intermittently fast, it's much easier to just then like eat fat. Because then you're like, oh, I don't mind this avocado ice cream. It's delicious because you're starving. But your brain does actually kind of function better on fats. I think the theory is that it goes back from when we were hunter and gatherers and had to go for long periods of time without food and had to function. And so the carbs, not that carbs make you dumb, but they, you want to take a nap.
Yeah, there's also, they speculated that, we don't hear about this a lot about ketogenic diet and seizure because it's being suppressed by all these companies that needs to keep selling Keppra.
Interesting.
Now we veered into conspiracies.
And it's it, right? It's also like something you can do. Like you put the control into the person. I mean, I've seen miracles, like true. I have a woman who has refractory generalized epilepsy on 4 meds, seizing every single day. And if she's on the ketogenic diet, she's seizure free and can come off her meds. Like it is like we see magic only rarely, I feel like, in the things we do, and that diet is magic.
Wow.
But it doesn't work for everybody. But when it works.
Thank you so much.
Thank you.
So much, Dr. Fields. It was amazing. Thank you.
No, you're so welcome. I thought maybe the silence and the no questions was like, that sucked, but thank you.
You got to prime them a little bit, right?
Okay.